Hey everyone, it's Josh at Prescription Fitness Physical Therapy and Sports Care here in Geneva, New York, bringing you another video for National Physical Therapy Month here in October. We're almost done with the month, so I thought I'd just quickly discuss common tennis elbow. What is tennis elbow? Tennis elbow is really irritation or tendinopathy that involves the common extensor supinator mass, which is a group of tendons that start here right on the apex of the elbow. So if you bend your arm to 90 degrees and you kind of poke at that really bony prominence, the insertion point is here, and there's another tendon that's slightly above that point. These tendons come down, and they come down into our hand, and they feed into our fingers along what are called the metacarpals. So these are extrinsic muscles of the hand, but what they do is they help to maintain the wrist position often when we grip and grasp. So if you look at my hand here, so I'll turn on side, as I close my fingers, you can see that my wrist moves backwards. And the reason it does that is because it's trying to maintain these length tension relationship of the muscles on the palmar aspect, or the palm side of my hand, so that it keeps the power as I go to grip and grasp. So even though they call it tennis elbow, there's probably not a lot of people who develop it from playing tennis, but there certainly can be reasons for that. How do we diagnose it? Usually it's pain pretty localized right on the point of the tendon itself. There's actually two distinct areas that can be involved, what we call the tenoperiosteal insertion, which is where the tendon joins right onto the bone itself, or you can have it at the musculotendinous junction, which is where the muscle and the tendon come together, which is a little bit further distal down into the arm itself, maybe about a finger is too length down from that little bony prominence again if your elbow's 90 degrees. So how do we diagnose it? Well, certainly history will tell us a lot. Again, remember, if your physical therapist isn't spending enough time with you on the history, or your medical practitioner, they're probably not getting all the information they should be, because the devil's in the detail with all these things. Tennis elbow, lateral elbow pain can be coming from higher up, and that's a very common point that we got to make sure we screen through. So your physical therapist should be screening through the cervical spine if you come in with an elbow problem. So one of the easiest ways is, if we hold out our hand just like this, and we have the physical therapist or the practitioner push down on the middle finger, if it reproduces pain into that area, there's an increased likelihood that you have tendinopathy. Again, we're not using the word tendinitis. So tendinitis sometimes can be a misnomer, because a lot of times what they find, if they do a biopsy of that area, there are no inflammatory cells. So it's really, it's a breakdown, it's a degradation process of the tendon. So it's an overload, and structurally things start to fall apart. So if they biopsy, there's actually a gooey mass of dead cells in that area versus inflammatory cells. So it's not truly a tendinitis, it's a tendinopathy or a tendinosis. A little bit different in how we treat that. You can have acute flare-ups of stuff, so you can have maybe a tendinitis on top of a tendinopathy based on chronicity. But hey, that's a much longer point and story to go into. So usually that's how we figure it out. Or if we take your wrist and we kind of straighten your arm out here like this, we flex it and we rotate it, and we go here, pushing my hand, and you push out, and that hurts. And again, with history, good clinical examination, we got to screen through the shoulder, elbow, hand, wrist, forearm, and we come up with our diagnosis. How do we treat this? A lot of times it's trying to modify the activities that precipitated it. So if I'm doing things with a lot of repetitive gripping and grasping, I'm going to try to maybe grip a little bit more lightly. I can wrap a handle of something, so I'm not having to clench as hard. Very often I'll have a patient wear what's called a cock-up splint at nighttime, because again, we all go into fetal positions when we sleep. And so if I do this at nighttime, then I'm putting strain on that tendon that comes down into my hand. So by being in a wrist splint or a cock-up splint, which holds my wrist more neutral, then that helps take pressure off, so I don't wake up in the morning on the negative side of things. Here in the clinic, we would hit it with our laser. We do soft tissue mobilization, instrument-assisted soft tissue mobilizations to create a mechanical stimulus, which can be converted over into a physiological change in the body called mechanotransduction. Again, big fancy word for what we do. And we'll hit it with some of the modalities, and then of course exercise. Exercises can look like concentric or eccentric. Concentric is a shortening contraction, so the muscle is actually shortening in length while developing tension, and eccentric is lengthening in length. There's different information out there, so eccentric seem to be better for tendinopathy and tendinosis, but you know how that goes. In another 5 years, eggs are good, eggs are bad, so I think you got to do a little bit of everything. But That is our quick one with tendinopathy. If it's an acute situation, you can also work on the inflammation piece of this. Certainly all your modalities such as ice is always a good one, but activity modification, careful diagnosis, and correct diagnosis is super important, because if it's coming from your neck and you're treating the elbow, guess what? You will not get better. So leave it up to your physical therapist. I think we're well positioned to really evaluate and treat a lot of these musculoskeletal problems, and we'll try to tease out whether or not maybe there's multiple components to it. So that's a quick look at tennis elbow.